Good morning, everyone. I'm Dr. Anvit Nanavati, and the topic I'll be presenting today is chronic inflammatory demyelinating polyneuropathy. So it is one of the cases that I saw during my rotation at AMIQD, and I'm grateful for AMIQD for this opportunity to present my case. So first is the case itself. The case is the patient is a 69-year-old male, right-handed, and he was ex-Navy. He was diagnosed by our team 2 years ago with CIDP, but he came here for a follow-up for one of his infusions and a follow-up on his symptoms with chronic inflammatory demyelinating polyneuropathy, which from now on I'll be referring to as CIDP. So initially, he presented with multiple classical features of CIDP, such as chronic fatigue, areflexia on all four extremities, progressive muscle weakness, which was chronically worsening over a period of 2 to 3 months. He also had numbness, which was on both the extremities, the upper as well as the lower extremities, but it was more prominent on the lower extremities. Regarding sensory loss, that was present in all the extremities as well, but it was 1+ on the lower extremities, meaning severe reduction in sensory. Uh, and regarding upper extremities, it was 2+, which is a moderate reduction. He also had a wide-based gait. And for this, when we diagnosed him with CIDP, we began IVIG infusions. And after taking it for multiple months, the patient had an 80 to 90% improvement in his symptoms. And for the follow-up, which he came a week back, he was 95% improved. Reflexes came back, muscle weakness was majorly reduced, gait issues were gone, and he was not fatigued anymore. And his sensations were back by 95% as well. Regarding family history, diabetes and hypertension was present on both the mother and the father's side. And regarding past history, I've clubbed past medical and past surgical. So in the past medical, the patient himself had diabetes, was hypertensive, also had asthma and obstructive sleep apnea, for which he was using a CPAP, which he mentioned was quite useful. And in past surgical history, he had a cholecystectomy 5 years ago and an appendectomy 6 years ago. Now, before I proceed, I just want to give a rough outline of what I'll be talking about in the subsequent slides. So the first would be a little bit about CIDP itself. So an overview, going to history, which is one of the first cases diagnosed, epidemiology, etiology, a little bit on its pathophysiology, as well as some clinical features seen in CIDP, the subtypes of CIDP, the diagnostic criteria, whether it's motor or sensory, a few differential diagnoses, and finally the treatment. So regarding the overview, what is CIDP? CIDP is an acquired immune-mediated disorder, and that normally does involve the Schwann cells, which are found on peripheral nerves. And when they're damaged by maybe environmental agents or infections, it can cause progressive demyelination in the form of segmental demyelination. At the same time, the good thing about CIDP is that the prognosis is quite good. If treatment is started on time, patient usually improves 90 to 95%. In some cases, close to 100%. But unfortunately, there are a few cases where you can still see significant disability, which is around 15%. There are some features that are not found in every patient, but are still found in CIDP nevertheless, such as autonomic dysfunction, maybe in the form of orthostatic hypotension, hypohidrosis or hyperhidrosis, or inability of the body to spread heat across the body, which means cooling the body. Symmetric paresis is noted as well. Progressive symptoms mainly in the form of muscle weakness, as well as certain preceding risk factors, such as maybe any infections or any agents. So if I may go back to the previous slide, the case itself, as you can see in the figure, that's the orange agent is actually called Agent Orange. And that's the interesting thing because our patient got CIDP through this agent. He was an ex-Navy and he was exposed to this agent, and which is why in his case, he directly got CIDP. He did not progress from AIDP or the acute form. He directly went to CIDP. Regarding the figure on this slide, it's actually a GABAergic neuron. And we know that because the red fluorescence in this image is actually because of a fluorescent dye called TD tomato, and that is specific for GABA neurons. So the red color senior is essentially GABA, and as you can see, the nerve, which is divided in three parts, which I've mentioned below, the proximal, the nerve bridge, and the distal nerve. So when it comes to the nerve bridge, as you can see, there's almost no GABA because of the segmented demyelination, which is why the nerve is kind of broken in transmission, if you have to say, and that causes motor and sensory symptoms. The hallmark of CIDP, as mentioned, is mainly segmental demyelination, which is seen in this picture as well, which progresses to axonal degeneration if not treated on time. Regarding history, one of the earliest documented cases of CIDP was in the 1800s, mainly the 1890s. And the case was a child, an 8-year-old child. And the symptoms at that point of time were generalized motor and sensory loss, areflexia, progressive muscle weakness as well, chronic fatigue or lethargy, and gait issues, which would also cause coordination issues. Unfortunately, in those days, since it was one of the first cases diagnosed, no one knew how to treat it, or what what was CIDP, which is why unfortunately the child succumbed to his death around 11 years of age. But the image on the right, that is of a different patient diagnosed around a similar time, 5 years later, a 31-year-old male. And as you can see in the about two images, the first one, which is at 2 weeks after the onset of symptoms, there is mild muscle weakness, and he was not able to extend or flex his arm. But in the subsequent one below, which was 9 months later, without any treatment being sought out, you can see there's a major uh, issue in there's a lot of muscle atrophy, inability to flex or extend, as well as certain contractures develop because of lack of movement. Unfortunately, even this patient died a few years later. Regarding the epidemiology, a little bit about CIDP. So in the United States alone, there are around 60,000 cases, but comparatively, compared to AIDP, this is an uncommon condition, or not as common as AIDP, which is why the annual incidence is 0.3 for every 100,000 people. At the same time, the peak incidence in terms of the age of onset is between the fourth and sixth decade of life. And the male to female ratio is a 2:1. Regarding the geographical and racial distribution, it is higher likely that patients from populations such as North America, South Korea, as well as certain parts of Japan get CIDP. And some of them are genetically predisposed as well. Regarding the etiology, as mentioned, it's an acquired polyradiculopathic disorder, and this condition is affected by various factors, whether it's genetic or environmental. So some of the genetic factors I will be talking about in the next slide, and some of the environmental factors are also listed below. And I've divided as to strong, moderate, and weak risk factors. So regarding strong risk factors, the genetic predisposition, because if it's in certain HLA genes, unfortunately, there's nothing you can do about it because some genes are protective and some increase the risk of getting CIDP. Again, something I will be talking in the next slide. Regarding moderate risk factors, autoimmune disorders such as SLE or multiple sclerosis, anything that affects the nerves, damages the nerves, can also increase the predisposition of getting CIDP. When it comes to inflammatory disorders such as IBD or Crohn's disease, ulcerative colitis, they have also been shown to have a higher risk than the general population for CIDP. When it comes to the weak risk factors, it's organophosphates like insecticides or pesticides, as well as air pollutants, mainly found in exhaust fumes such as nitric oxide or just sulfur. So even though they're weak, unfortunately, we are exposed to those risk factors more commonly, increasing the risk of the general population by around twofold. So as mentioned earlier, these are the genes that do increase the risk of CIDP. So the first one is HLA DRB star 1, O3, and O7. Both of these genes don't need to be found together, but they increase the risk fold by 2 times mainly in the Tunisian population. When it comes to another HLA gene, which is HLA-DR3, as well as DRQ2, that's mainly found in the Italian cohort population. So having these genes doesn't necessarily mean that you would get CIDP. But if you do get CIDP, your chances of it being a more severe variant or chronic variant is on the higher side. Now, regarding genes, there are also some that are protective, such as ICAM1 or AIRE, which is the autoimmune regulator gene. As you can see in the picture on the right, the one on the top, there are two ICAM1 genes. But in figure A, that's the normal ICAM1 gene, whether it's in terms of the size or the length, which is 132 kilobase pairs. But the one on the left, on the right, which is B, as you can see, it's comparatively significantly reduced in size and weight. And when the gene gets defective, that's how it looks. And the size is reduced and it can no longer protect the body from CIDP or any autoimmune conditions. And they are more prone to getting CIDP, as mentioned earlier. And then the one below, that's AIRE or autoimmune regulator gene. All the three pictures are the same gene, but they progressively reduce in quality and structure. So as you can see, the topmost part of the image, it's well maintained. You can see each cell structure, but progressively compared to the middle one and the one on the lowest, it is now reduced to a globular structure. That's it, because it can no longer protect the body from CIDP as the autoantibodies have targeted the gene, removing its ability to protect the body. Regarding the pathophysiology, as mentioned, there are many environmental factors and genetic factors, maybe Agent Orange, infectious diseases, GBS or Guillain-Barré syndrome, which would then progress from acute demyelination to chronic demyelination, or AIDP to CIDP. So what happens is that when these infections or agents are brought close to a human or any patient, what happens is these agents target the cells, which in turn affect the nerves and lead to segmental demyelination. Now, usually the body will heal this and lead to remyelination. But unfortunately, in CIDP, this thing is a cycle, and demyelination occurs again and again to a point where the body can no longer remyelinate it as fast as it's being demyelinated, which in turn leads to polyneuropathies, motor symptoms, sensory symptoms, and atreflexia. And this, if not treated on time, or maybe turns into a more severe variant, can cause axonal degeneration. And that, unfortunately, is one of the features which leads to a person going into the significant disability of 15%, where treatment doesn't help the patient that much. Regarding the clinical features, the features that are mainly seen in CIDP patients is numbness and tingling throughout both the extremities, the upper and the lower extremities, also progressive muscle weakness to a point where they can no longer even flex and extend their extremities. Areflexia is normally seen in all four extremities. Muscle cramping, as well as a wide-based gait that's normally found in these patients, mainly because of muscle atrophy as well. And in some cases, such as 10 to 15% of cases, there are also cranial nerve palsies or nerve involvements, mainly the third nerve, the seventh nerve, and the phrenic nerve. Third being the oculomotor nerve, and seventh being the facial nerve. In some cases or atypical variants of CIDP, you may also have a high preponderance of bulbar symptoms, such as dysphagia, dysphonia, dysarthria. Autonomic dysfunction, as mentioned earlier, in the form of orthostatic hypotension, hypohidrosis, or hyperhidrosis, or the inability of the body to disseminate heat throughout the body. Tremors are seen in around 10% of cases, and they do resolve when treatment is sought on time. Asymmetric allodynia is something that is unique to CIDP as well, in the form of it just involving maybe one of the extremities, either the upper limbs or the lower limbs, which is not the case in the acute form, in which the allodynia is usually symmetric if present. And there are also pure variants of CIDP, pure indicating pure motor variants or pure sensory variants. Regarding the subtypes of CIDP, there are mainly 5 subtypes, and I will also be talking about the pure variants later on. So the first one, which is one of the most common subtypes, is multifocal CIDP. Multifocal, meaning it includes sensory as well as motor dysfunctions, mainly in the form of progressive muscle weakness, areflexia, as well as sensory loss throughout the body, mainly the upper and lower extremities as well. It also follows an asymmetric pattern initially, which is more common. And as mentioned, both extremities are involved, but the asymmetry or the reduction in sensory and motor loss is more on the upper extremities. The second one is a focal type or a focal variant of CIDP. In this case, sensory and motor loss both is present, but it's mainly limited to just one limb, maybe the upper or the lower extremities. But in the focal variant, it's a little more common to be on the lower variants, lower extremities. Regarding distal CIDP, which is the third variant, there is, as the name suggests, there's distal sensory and motor loss. Progressive muscle weakness is present, but it's more on the lower extremities. And regarding the final two variants, which come under the pure variants, the first one being a pure motor CIDP, which is an almost complete reduction in motor usage or motor nerves being affected, giving rise to muscle weakness and various other signs and symptoms. But sensations are usually more or less intact. But when it comes to the pure sensory variant, as the name suggests, in this case, sensations are almost completely reduced or absent, but the motor response of each nerve is usually present. Now, regarding the diagnostic criteria, there are four main types. One is the clinical criteria, the other one is a motor nerve conduction criteria, the third one is a sensory nerve conduction criteria, and the fourth one is CSF findings. So first to talk about the clinical criteria. So there are three main sub criteria that we look for. So in the clinical criteria, we look for a progressive weakness which gradually worsens over an 8-week period. At the same time, areflexia has to be present in all four extremities. And at the same time, any motor or sensory symptoms that begin have to go in a symmetric pattern, mainly distally. Regarding the motor nerve conduction criteria, there are quite a few, but the top three are the most commonly used ones are regarding the nerve conduction studies. So the first one being a prolonged motor distal latency of at least 50% higher than the upper limit of the normal in two nerves at the very least. The other one is a reduced nerve conduction velocity of at least 30%, 30 to 50%, again in at least two nerves, which would in turn cause a lot of denervations and they would affect the latency speeds, causing polyneuropathy and other signs. And the third one is an abnormal temporal dispersion of at least 30% increase over the normal limit, which would indicate that the nerve has been damaged to a point where the difference between the proximal and distal part of the nerve is so much that even though the action potential is fired from the same nerve, each muscle fiber gives differently. Each muscle fiber reaches the electrode at a different time because of the reduced nerve speed. Regarding the sensory nerve conduction criteria, that would indicate an abnormal snap or sensory nerve action potential amplitudes. Mainly they are reduced. At the same time, there are sensory nerve latencies, which means because of a slower speed of the nerve, because of the demyelination, the nerve has a prolonged latency period as well as reduced conduction velocities, which again are responsible for a lot of sensory symptoms. And the fourth one being the CSF findings, which is in the form of albinocytologic dissociation, indicating elevated protein levels with a normal cell count. So regarding the differential diagnosis, there are quite a few, but I've chosen the ones that are closed in mimicking CIDP. One of them being quite fairly common and the other two being a little on the rare side. So Guillain-Barré syndrome is the one that's a little on the common side, and multifocal motor neuropathy and transthyretin familial amyloid polyneuropathy, they are a little bit on the rare side. So for ease of discussion, I'll be referring to all these three conditions in the short form: GBS, MMN, and FAB for the amyloid polyneuropathy. So the median age for GBS is the third decade of life, compared to a difference of almost 10 years each when it comes to MMN, which is the fourth decade of life, and FAB, which is the fifth decade of life. The sensory involvement is present mainly in the GBS variant as well as FAB, or amyloid polyneuropathy, but is completely absent in MMN because the name suggests it's only motor involved or motor neuropathy. So sensations are usually intact in that condition. Regarding gait abnormalities, in all these three diagnoses, gait abnormalities are present and may mimic CIDP. Hence, it gets difficult to differentiate these conditions from CIDP just on the basis of a gait or a wide-based gait. But regarding steroid efficacy, that's where the major difference lies, because steroids are very effective for CIDP, unlike GBS, MMN, and FAB, where it is not at all effective, and in some cases is not even recommended, as it can worsen the already present clinical features. Regarding nerve palsy, that is something that also doesn't help much because it's present in all these three conditions as well, though it's present a little bit more, around 30 to 40% of cases of FAB, because the amyloid directly gets deposited in the nerves, which would worsen the polyneuropathy. Regarding autonomic dysfunction, it is present in around 35% of cases of GBS and around 50 to 60% of cases of FAB. But when it comes to MMN or multifocal motor neuropathy, it is absent. Regarding asymmetric allodynia, that is usually absent in GBS and MMN. So in GBS, allodynia may be present in around 10 to 15% of cases, but it is usually symmetric. And when it comes to FAB, it may or may not be present in the form of an asymmetric variant in just around 10% of cases. Regarding the prognosis, no matter how rare or common these conditions are, fortunately, they also have a good prognosis, such as CIDP. When it comes to the treatment, are divided into two forms. One is the mainstay and the other one is a novel treatment option. So when it comes to the mainstay treatments, IVIG is the go-to. IVIG or immunoglobulin infusions every month significantly help in reducing the symptoms as they directly replace the immunoglobulins, mainly the IgG, which are the autoantibodies targeting the nerves. Plex or plasma electrophoresis is also another good option, as it's similar to IVIG in the sense of removing autoantibodies, but in this case, it also replaces the plasma proteins, which are normally reduced in this condition. Glucocorticoids are quite useful, and in some cases are given as an adjunct to the above-mentioned infusions, as glucocorticoids can directly reduce nerve inflammation, giving the ability to the nerve to heal, repair, and reduce the symptoms temporarily if used alone, the motor and sensory symptoms. Regarding immunosuppressants, they are not commonly used but can be used, and such as tumor necrosis factor alpha inhibitors or 5-ASAs or alpha salicylic acid. But again, they have to be used with the above mentioned treatment options for the best efficacy. Regarding novel treatment options, these are treatment options which are fairly new. They've come out in the past few years. The first one being Vyvgart Hytrulo. So it is nothing but a combination of a monoclonal antibody and hyaluronidase. The monoclonal antibody being efgartigimod alpha and hyaluronidase QVFC. QVFC is nothing but the proprietary variant used in this medication. And this medication is FDA approved as well. So how this works is that it neutralizes the autoantibodies present by binding to various immunoglobulins, mainly IgG. So what happens is that when Vyvgart Hytrulo binds to IgG, the unbound immunoglobulins which were attacking the nerves, they are degraded by lysosomal degradation process, in turn reducing the number of autoantibodies affecting the blood-brain barrier or the nerves, in turn indirectly reducing the symptoms because of reduced autoantibodies. At the same time, The other one being Gamma Guard liquid is also FDA approved, and this mainly is, as the name suggests, it's just immunoglobulins, and these immunoglobulins also target IgG by neutralizing and opsonizing the autoantibodies, mainly IgG, and also indirectly help with nerve repair. Because if the immunoglobulins are reduced, there are no immunoglobulins to target the nerve, giving the nerve more time to heal, in turn reducing the motor and sensory symptoms over time. And the final one is Hyquia, which is also FDA approved. And in this case, this is a subcutaneous infusion. Subcutaneous is given subcutaneously, and this also has two components. One is the IVIG itself, or the immunoglobulin infusion, along with a human recombinant, uh, yeah, hyaluronidase. And the human recombinant variant, what it does is that it increases tissue permeability, which means that there's a higher dose of immunoglobulins that can enter through the subcutaneous variant, which means you may need lesser doses over periods of time if you can get more to just damage or remove the autoantibodies in the initial doses. So that was my last slide. Thank you all for your attention, and please feel free to ask any questions if present.